Ma'am, we are online.
Okay. Okay, thank you. Uh, I welcome all the participants and delegates for joining today's webinar. Thank you for joining Shield Connect. And this webinar is sponsored by South Asian Federation of Obstetric and Gynecology and NCD committee. So the today's theme of the webinar is obstetrical management in GDM, that is hyperglycemia, part 2. And before we start with the session, let me give a quick introduction of our MOC and coordinator, Dr. Amrita Sarkari Jaipuriar. So, fresh the CV Saidi. So, ma'am is a consultant gynecologist and obstetrician of Jaipuriar Medical and Research Center and Garg Hospital in Gorakhpur, UP. Ma'am is currently president of Gorakhpur Obstetric and Gynecology.
That's okay. Thank you, Shield.
Thank you.
Thank you. Let's
Okay,
move on.
Yes, ma'am.
So a very good evening to the honorable guests, respected faculty, and dear attendees and viewers. A hearty welcome to the second of the series of the NCD webinar organized by NCD Committee of South Asian Federation of Obs and Gynae. In the previous one, we discussed about diabetes mellitus, the incidence and the problem, and today we are going to discuss the management part. We all know that NCDs account for around 40 million deaths each year all over the world. And we all know that the incidence is rising and diabetes is more in South Asia. And so we are here to discuss all this. So at the outset, I would love to call upon the President of CEFOP, Dr. Ruhana Hatatua, for his presidential address. Sir is from Colombo. He has held many international posts. He has been the Secretary General of Asia Oceania Federation of Obs and Gynae, has been the past chairman of Menstrual Disorder Committee of FIGO, and presently, of course, he is the president. He is also the president of World Gestational Organization and past president of Sri Lanka College of Obs and Gynae, past president of Menopause Society of Sri Lanka. So over to you, sir, for your presidential address. Dr. Rohana, please, over to you.
Muted, sir.
Sorry, I have been muted. So thank you. Thank you, Dr. Amita, for your kind words of introduction. I am very happy to be here in this, the second of the series of webinars organized by our NCD, Suffolk NCD committee. I mean, we have a very energetic and dynamic chairperson and a co-chairperson, Dr. Padam Raj from Nepal, and of course, Dr. Sadhana Gupta from India. I mean, they are very active and involved in organizing these webinars. So I think we also have to move with them and without having much rest in between. But I'm thankful to them for keeping us all alert. So this program today is also the continuation of the first program, which was held a few weeks ago, related to the NCDs and especially concentrating on gestational diabetes mellitus. As we all know, this diabetes mellitus in pregnancy is a real issue for all the practicing obstetricians, and also it is a cause of maternal and perinatal morbidity and mortality. So, and also we know that the management, everything is changing day by day, and we have to keep pace with all these changes which are taking place, so that will benefit our patients. So I see that in today's webinar, all these things are being discussed, and we are happy to see so many expert speakers. And I'm thankful to all the Suffolk officers. I see Professor Dr. Lubna Hassan from our Vice President. I mean, she's very cooperative and very helpful with all our programs, and also Dr. Farhana Devan, our Deputy Secretary General. I mean, she is also very involved with all the programs. So that is a great strength to us in Suffolk, and so many others from our member societies, including Nepal, Afghanistan, Bhutan, Bangladesh, Pakistan, and Sri Lanka are joining. So I think they may be joining later. So there is a great program ahead of us. So without taking much of your time for the program, I will hand you back to the moderators to continue with the program. Thank you very much.
Thank you, sir. Thank you for the wonderful, encouraging words. And these words keep us going. Now it is time to hear Dr. Padmaraj Pant, who is the chairman of NCD Committee of CEFOG. He is professor and head of the Department of Obstetrics, Tribhuvan University, Institute of Medicine, Maharajganj Medical Campus. And he is the author of many books on pregnancy, safe motherhood, infertility, management of cancers, and so on. And he has also written a textbook of gynecology. Over to you, sir. We need your blessings.
Thank you, Dr. Amita. Respected President, Secretary General, CEFO, co-chair of NCD Committee, speakers, and attendees. Thank you very much. Without taking much of your time, I would like to welcome you all in this CME program on gestational diabetes. We have gone through the diagnosis and diagnosis of the gestational diabetes, and today we'll go through the management of gestational diabetes. So welcome you all on this in this CME program. Thank you very much.
Thank you, sir, for the kind words. Now it's time to call upon the organizer, the chief organizer of this program, who is very instrumental in all the academics we do here at Gorakhpur and in India. And she is famous all over. And she is an amazing organizer and a leader. I can go on and I have so many adjectives for us, but for now, she is the co-chair of NCD Committee of CEFOG. She has been the FOXI representative to CEFOG and Vice President FOXI in 2016. She is author of many books, author of book on obs and gynae, which has been translated in different languages, has many publications and awards to her credit. So over to you, Sadhna ma'am, to welcome our chief guest, our special guest, Dr. Alka Kriplani and Dr. Yusuf Latif Khan. Over to you, ma'am.
For kind introduction. For some reason, I think Dr. Alka Kriplani is busy and we are not seeing Dr. Yusuf in that list, and they may be joining a little bit. So we can introduce Dr. Alka Kriplani, and as a co-chair, myself and Dr. Padmaraj is very happy to welcome you, and warm regards to President CEFOG, Dr. Ruhana, and Dr. Yusuf, and our special guest, Professor Alka Kriplani. So NCD, as we know, it is one of the major challenges in South Asia, and on every second Friday, with the permission and approval of our President, Dr. Ruhana Hatoguya, we will try to do our best with Dr. Padmaraj Pant and the dedicated team of the CEFOG NCD committee for certain vital issues which are important in the field of NCD in South Asia. So Dr. Alka Kriplani is our very beloved and the motivating person, and she has been President FOXI. She was founder President of Gynecological Endocrine Society of India, President AOGD, editor of many journal and on the editorial board. She has been awarded the highest national award, that is Padma Shri and the Dr. B.C. Rai National Award, Honorary Fellowship of RCOG, and many awards. She is a wonderful surgeon par excellence, teacher par excellence, and a wonderful human being. So we seek her all the best wishes, and once she joins, and we will like to have her comment. And Chitra, please let us know that when she joins. So we can say Dr. Sadia. So we can go ahead with the scientific session, and with the Dr. Padmanabh, we are going ahead with the scientific.
Sure, ma'am. Sure.
Yes, please.
Okay, ma'am. So quickly moving on to the scientific session. The first topic is fetal surveillance in GDM. And the speaker is none other than Dr. Aparna Sharma. For this, I would like to call upon our respected learned chairpersons, Dr. Sadia Ehsan. Dr. Sadia Ehsan is the chairperson, Maternal and Fetal Health Committee of CEFOG. She has been the ex-vice president, Society of Obs and Gynae of Pakistan, and a co-chair at the academic board. She is also the member editorial board, Journal of Pakistan Medical Association. So welcome Sadia ma'am on this platform. And our second chairperson is Dr. Farhana Diwan. She's the President-elect OGSB, Deputy Secretary General CEFOG. She's also the head of the Department of Obs and Gynae, IBN Sena Medical College, and Deputy National Coordinator, FIGO PPH Bundle Project Bangladesh. So over to chairpersons, and now I would request Dr. Sadia to kindly introduce Dr. Aparna and introduce the subject to us. Over to the chairpersons.
Thank you, Dr.
Amrita. I'm Amrita.
Amrita. I'm sorry, I'm traveling, so I'm trying to be good, So without wasting time, I would like to introduce Dr. Aparna Sharma. She is Additional Professor, Division of Maternal Fetal Medicine, Obstetrics and Gynecology, AIMS, New Delhi. Fetal medicine specialist with expertise in fetal interventions. Kamini Rao Orator 2017, Foxy Junior Korean Award, Foxy SUNIAEC International Traveling Fellowship 2019, Foxy Imaging Science Committee Award, Foxy Rajat Ray Award in Fetal Medicine, APJ Abdul Kalam Appreciation Award, Chairperson AOGD Quality Committee, Joint Secretary, Society of Fetal Medicine, North Zone Coordinator, Safe Motherhood Committee, Co-Convener, Early Pregnancy, SIG, Indian Fertility Society. She is also the North Zone Coordinator, Practical Obstetrical Committee, and has several publications in international peer-reviewed journals. So we're really honored to have her with us today. And I will not waste further time. We'll move on with the topic. Would you like to start your presentation?
Dr. Aparna? Yeah.
Thank you, chairpersons, and I'm really thankful to Dr. Sadhna ma'am for inviting me here today, and I'm really honored to be here among such august gathering. My topic here today is to be talking about antepartum fetal surveillance in diabetes, and especially gestational diabetes mellitus. So when we talk about antepartum fetal surveillance, I started by thinking about, the typical fetal surveillance that we talk about, but then I actually retraced my steps and I thought about, what is my goal when I talk about fetal surveillance? So I thought that when we talk about fetal surveillance, our goal is actually to make the fetal journey safe. So we have to start where the fetal journey starts. So when we talk about fetal surveillance, we have to start by starting where the gestational diabetes starts, and that is where the pregnancy starts. So just to have a look at gestational diabetes, where we start by defining gestational diabetes by some of the criteria that we use. In India, we use it as by a single step procedure where we define GDM by a value of more than 150, excluding the values when they go beyond 200. Different countries use different values, but universally it is thought that if the values go beyond 200 or a HbA1c going more than 6.5, we will take it as a pre-gestational diabetes. So going into that criteria, fetal surveillance actually starts in the first trimester. So we have to start with the fetal surveillance in a mother who's diabetic in the first trimester itself. And we need to remember at all times that a lady who has a blood sugar more than 140, whenever a patient comes to us, so in India, we typically follow that anytime a patient is coming to us and we do a single blood sugar value, giving a 75-gram challenge, and she's declared to be a diabetic, a gestational diabetic, we need to call her a gestational diabetic, and we start looking at the fetus at the same time. And if she's coming to us in the first trimester, we also need to look at it, that if the diabetes is affecting her first trimester aneuploidy screening. So we start from there. So the fetal surveillance in diabetes starts right from the first trimester. So what does the evidence say? So are the prenatal aneuploidy screening markers affected by gestational diabetes? So evidence says that there might be some of the effects. While we know that the aneuploidy itself, the incidence of aneuploidy itself may not increase in gestational diabetes per se, but the marker, the level of markers may be lower in women who develop diabetes later on in pregnancy, while as compared to women who remain normoglycemics. And hence it's important to keep this thing in mind. So please remember that a woman who's gestational diabetes, when you diagnose, or even a woman who wants to develop gestational diabetes, we need to offer routine aneuploidy screening. Dual and the NT remains the best method with a good detection rate. And we need to mention, if the you have already done a 75-gram value test for her in the first trimester, and you have diagnosed her to be gestational diabetes based on her criteria, then in that case, please mention that she is diabetic in her requisition form, because the values may differ according to her diabetic status. So that is the key message number one. Now, what about her key fetal well-being in the second trimester? So then again comes up next question. Now, does diabetes affect the second trimester aneuploidy screening markers? So we know that pre-gestational diabetes requiring insulin, the markers do get affected. And this is also dependent on the levels, the glycemic levels in the second trimester, and alpha fetoprotein specifically gets affected. And if it is a type 1 diabetes, the alpha fetoprotein levels are reduced by 10%, whether the patient is managed by insulin or oral hypoglycemic agents. Then again, we have, if you look at these forms, so these are typically the forms that we are asking, and we are filling those forms for our patients. So there is a column which mentions diabetes, and including the origin and the diabetes. And why is this there in this form? Because we know that the diabetes is going to these form, the values are adjusted for diabetes. So interestingly, I have mentioned this form here because the values have to be adjusted for diabetes, so that it is adjusted, and the values, they do not give us a false positive if we do not mention this and the values are not adjusted. So whether it's a triple marker, whether it's a quadruple marker, we need to keep that in mind and mention that in the test. So the message number 2 would be that if we have missed the first trimester screening, then we need to offer the quadruple test in the second trimester for the purpose of aneuploidy screening. And again, please remember to mention the background prevalence in the form, requisition form, that this patient is a diabetic. Now, the third issue, when we are thinking of fetal surveillance is, does the gestational diabetes increase the rate of fetal malformations? Now, thankfully, we all know that gestational diabetes does not increase the rate of fetal malformation. We know that the embryopathy in diabetes can be attributed to hyperglycemia early on in pregnancy, which may not be, seen in gestational diabetes because it is related to decrease inositol, decrease PGE2, decrease arachidonic acid. So all of this embryopathy in diabetes, we know that it is more in pregestational diabetes. We know that it is in insulin dependent diabetes, type 1, type 2 diabetes. And yet it is very important to keep in mind fetal surveillance when we are taking care of a fetus of a gestational diabetes, that we offer anomaly scan for all women as we do in the second trimester. And we know that although GDM does not predispose to anomalies, no opportunity for routine screening should be missed with diabetes or without diabetes. Now, the next point is fetal well-being in the third trimester, and the most important aspect of being a diabetic mother. So what is the most important concern regarding gestational diabetic? So we know that it is the fetal growth concerns. So the large for gestational age and macrosomia. So what is large for gestational age is when we are suspecting that the fetal growth is more than the 90th centile for that gestational age. And macrosomia is the absolute weight of more than 4.5 grams. So why we are concerned about this is because both of them are known to be associated with adverse neonatal outcomes. And it has been seen that both of them occur to a tune of almost between somewhere 15 to 20% in cases of gestational diabetes. So it has been seen. So it is a outcome of concern, and we should be completely concerned about it. So if there is a mother who's gestational diabetes, and along with that the mother is obese, there is almost a twofold higher risk. And on top of that, the mother has had an excessive gestational weight. So we should be aware that, okay, this lady also has an increased risk of a large for gestational weight, and we should be on the lookout for it, that, okay, this baby might be having a large for gestational age. And the background reason being the Pedersen's hypothesis, the maternal hyperglycemia leading to transplacental transfer of glucose, hyperinsulinemia, and accelerated fetal growth. So all of this leads to large for gestational age baby. But then again, the most challenging question being, how do you estimate the fetal weight? And all of us who do the ultrasound, we know that how much of a discrepancy we find in the fetal weight. In fact, there is no method of fetal growth assessment that uniformly performs well. It's actually easier to estimate smaller babies than bigger babies. The methods that are currently available, they are actually difficult for the bigger babies. And in fact, in one of the reviews, they said that 50% of the time we are overestimating the weight landing up in cesarean section while the babies are actually smaller. So while they do present a challenge, which are the better methods to estimate? So it has been seen that the best method, of course, which with the better sensitivity would be a combination of BPD, AC, FL, but AC alone also provides a greater sensitivity. So in fact, an absolute value of AC of more than 35 does provide a good estimate that, okay, maybe this baby is going to be big. But yes, for AC, for a weight of more than 4.5 kg, AC does give us a good estimate that, okay, this is going to be big. And serial ACs is also going to help us, that serially is going to increase. So now how do we monitor growth in such babies? So what are the options? Option number one is, some of us, what we do is that we will do a single ultrasound in the third trimester between 36 to 39 weeks as a surveillance method to estimate the fetal weight. And we would say, okay, this baby is big, so let us decide what is to be done about it, whether this baby can deliver normally or not. Now, the second option is that some people will say that, okay, I will do an ultrasound between 28 and 32 weeks to see if this baby is going to grow rather rapidly. And if the baby is already big, this is a sign that this blood sugar is not being controlled properly, and this mother really needs to control her blood sugar properly. And also identify women who might benefit from an early induction. Option number three, and maybe more suitable for resource rich settings is that you do ultrasound every 4 weekly to identify accelerated fetal growth and also titrate the blood sugars better. And option number 4 is in those settings who feel that, okay, they are euglycemics, they are diabetic on diet, and they are excellently controlled, so you do not at all monitor. So these are the people who are completely against antenatal fetal surveillance, and I will talk in a bit about it towards the end of my talk. But out of the option 1, 2, and 3, a reasonable option is at least one single ultrasound in the 3rd trimester to estimate the fetal weight, so that we don't land up in problems like obstructed labor and shoulder dystocia, because we do know that diabetes babies do have preferential deposition of fat around the shoulders, and they can land up in shoulder dystocia. So at least an option number 1 to ensure that we know that there is an estimated fetal weight with us and we know how big the baby is. So that's a reasonable approach for fetal monitoring of growth. So the key message number 4 would be that fetal growth is of concern in mothers with gestational diabetes, especially those with uncontrolled sugars, and monitoring should be done at least once in the 3rd trimester by an ultrasound estimation of fetal weight. Now, the most important aspect, of course, remains stillbirth, and the entire gamut of fetal surveillance is directed against that stillbirth. So is the risk of stillbirth actually increased in gestational diabetes? What are the causes? Why are they at risk? And how to prevent it? So that's a big challenge. So stillbirth, when we talk about in diabetic pregnancies, especially in gestational. So when I talk about pre-gestational diabetes, type 1 diabetes, I don't think anybody has any doubt on that. We all agree, yes, pre-gestational, type 1, everybody is at risk. But what about gestational diabetes? There seems to be a slightly increased risk, but the data is observational, not very strong. One of the largest reports regarding GDM had a stillbirth rate of 5.4 per 1,000, while the non-diabetic controls has 1.8. But because of these small numbers, they were not statistically significant. But aggressive management improves perinatal outcomes. So we cannot outright say that, we cannot do an antenatal monitoring is not justified. So there does seem to be slightly increased risk of stillbirth, and there seems to be some logic in trying to say that, yes, this does require antenatal monitoring. Causes of death, if we look at it, in diabetic pre-gestational versus gestational diabetes. So if you look at this table here, the gestational diabetes, the causes of stillbirth still remains the lethal malformation cause are the main cause of stillbirth in type 1 and type 2 diabetes, while in gestational it is mainly unknown. So not very frequently the malformations will not occur. Some of the umbilical and placental abnormalities may still account for some of the causes in gestational diabetes. So largely unknown, but yes, I mean, we are still not very sure of what are the causes for stillbirth in gestational diabetes. So what is the possible hypothesis of stillbirth? Hyperglycemia, poor blood sugar control. The other half could be like infection, and significant proportion would remain unexplained. So if unfortunately the stillbirth occurs, definitely we will need to evaluate the cause with a detailed autopsy and placental evaluation. So obesity is a big risk factor which really needs to be looked into, along with congenital birth defects if present, prior cesarean delivery, and fetal growth restriction. And one of the major things that of course remains to be seen is the Pedersen's hypothesis, where hyperglycemia, hyperinsulinemia, accelerated growth, and relative fetal hypoxia always comes into play. And the latest hypothesis is the cardiac dysfunction, and a lot of studies are going on into the cardiac function in the fetuses with mothers having diabetes. So one of the basic pathophysiology behind stillbirth which are being studied is this. So how to prevent? And I think this is the major area of focus is preconceptual care, glycemic control, antenatal fetal surveillance, timing of delivery, and intrapartum care. And I would be talking a bit more in detail about the antepartum fetal surveillance. Starting with the basic and the most simple and the most widely prevalent is the fetal movement count, because we feel that there is a universal consensus that if the woman feels If the woman feels that there's an absent or a reduction in the count, then the obstetrician should definitely consider this and should further do an assessment, because this is considered as a sign of decreased placental perfusion and fetal acidemia. However, the problem is that there is no clear alarm limit which can indicate when the risk of fetal death or injury is increased. What are the methods? One is the Cardiff Count, which suggests that they count to 10 movements in a fixed time frame of 12 hours. The other is Sadowski's method, which suggests a count of movement in a specific time frame, usually 30 minutes to 2 hours. Fetal sleep cycle lasts for about 20 to 40 minutes. And hence, ACOG says that less than 10 movements in 2 hours is abnormal. So if we are fixatedly looking at fetal movements and there are no 2 movements in 2 hours, then maybe we should move on to the next method of assessment. So this was a bit about the fetal movement count. The non-stress test is always the mainstay of antenatal surveillance, with or without the amniotic fluid. So in a series of around 2,000 women with diabetes, twice weekly NSTs were done, and no stillbirths occurred within 4 days of the last antepartum testing. So most centers would use this non-stress test, which is actually based on the fetal heart rate accelerations. So it is performed during the antenatal period when the uterus is relaxed. The woman should empty her bladder, be positioned on either a bed or a reclining chair, and the recording should last for 20 minutes. Now, this is a good reactive NST where the baseline is between 110 to 160 with a variability of 6 to 25, at least 2 acceleration of 15 lasting for 15 seconds. The negative predictive value is 99% within 1 week. What to do if your NST is non-reactive? Then you wait for at least 40 minutes. And if it is because it's a sign of interrupted fetal oxygenation, the other could be immaturity, fetal sleep, maternal smoking, or other neurological or cardiac anomalies. And if it is still unreactive, then repeat in 30 minutes, perform a backup test, and if possible, modify the potentially modifiable factors. So this is what you do if the NST is non-reactive. Normally what we do is we do a biophysical profile and repeat it after some time. So the other thing that we always do is a biophysical profile, which consists of fetal breathing movements, fetal tone, amniotic fluid volume, and fetal movement. Each of them is given 2 points. If fetal breathing movement will be given 2 points if there are 1 or more episodes of rhythmic breathing movements of more than 30 seconds within the 30-minute observant period. Fetal tone, 2 points if 1 or more episodes of extension of a fetal extremity with return to flexion. Amniotic fluid if single vertical pocket of more than 2 centimeter, and a fetal movement is 3 or more discrete limb movements within the 30-minute observation. And it has been seen that it is associated with a rate of cerebral palsy. So if it is 0, there is a definite association with the rate of cerebral palsy with the last biophysical profile score. Similarly, the possibility of neonatal death increases as the score goes down. So as the score goes down, the possibility of the neonatal death has been shown to be increased with the biophysical profile. So if the biophysical profile is good, very well, 8 out of 10 or 10 out of 10, then no intervention. If it is 6 out of 10 with equivocal test, the test is to be repeated within 24 hours. Now, if it is 6 out of 10 with oligohydramnios, that is, it's an abnormal test, then there is a risk of fetal hypoxia within 1 week is around 90 out of 1,000. But of course, the scores need to be interpreted within the context of the gestational age. If it is 0 or 4 out of 10, then the risk of asphyxia is quite high and the delivery is usually indicated. Now, just a bit about the role of Doppler. Now, let us please understand here that in diabetes, we are more worried about a bigger baby than a smaller baby. Role of Doppler in a normally grown baby in the absence of growth restriction is actually very restricted. So we generally use Doppler as we would for identification of growth restriction. So if there is a small baby along with a uterine artery PI which is more than the 95th centile or an umbilical artery PI which is more than the 95th centile, then we identify that as an early onset growth restriction, which can occur in a diabetic which is uncontrolled with an underlying vascular changes, or in a late onset fetal growth restriction, if there is again a CPR, a cerebral placental ratio, which is changed. So the role of Doppler in, again, a diabetic pregnancy would be to identify the early or a late onset fetal growth restriction in terms of fetal surveillance. And once we have identified the presence of a fetal growth restriction, the role of the Doppler is in the fetal monitoring, because once we have identified, we have to classify fetal growth restriction. In the presence of an absent end diastolic flow, it becomes stage 2. In the presence of a reverse end diastolic flow, it becomes stage 3 fetal growth restriction. And then we will accordingly manage the fetal growth restriction, because if it is stage 1 fetal growth restriction, we will monitor this patient weekly and deliver at 37 weeks. Stage 2, we monitor it bi-weekly and deliver at 34 weeks. And stage 3, we monitor it daily and deliver at 30 weeks. And stage 4, we monitor it twice a day and deliver any time after 26 weeks. Just the counter view. There is some argument against routine antepartum fetal surveillance in women who have well-controlled diabetes and no vascular complication. The need for intervention for abnormal testing is rare. So in these patients, there may not be a role for antepartum testing in women who have only gestational diabetes mellitus. So these are very liberated people. There might be some people who might believe in this particular viewpoint of view, and there is evidence for this also, but that particular point of view may be supported by some people. So to summarize, antepartum fetal surveillance in pregnant women with diabetes appears to have improved outcomes in some form of antepartum surveillance in women who have diabetes which are on drugs, on insulin. However, there is a little bit not clarity on the best method, best timing, optimal gestation, and the accurate interpretation of testing. So in the diabetes with good glucose control, these patients do not appear to be at increased risk. So in these patients, you may have an option of not entirely doing the antepartum fetal testing. Those patients who are on diet and they are on good control and only on nutritional therapy. So in these patients, it may be optional. But in the patients who are on suboptimal glycemic control, or those patients who are well controlled, but in the patients who are on insulin or oral hypoglycemic therapy, these patients should be on continuous or antepartum fetal surveillance starting at 32 weeks for fetal well-being. So the suggested protocol would be that fetal growth rate at 28, 34, 37 weeks, once weekly non-stress testing from 33 to 34 weeks, fetal kick counting from 28 weeks onwards, high-risk pregnancies, more frequent ultrasound monitoring, non-stress testing twice a week, and Doppler examination of umbilical and uterine artery is mainly reserved for cases with fetal growth restriction and preeclampsia. So thank you very much for a patient hearing.
Thank you. That was excellent.
Yes. Dr. Farhana?
Yeah,
Dr. Sadia, we would love to have your comments, please.
thank
Okay,
you.
so I'll go first, Farhana, if you don't mind. Can I go first? Okay. Thank you for an excellent presentation, Dr. Aparna Sharma. I apologize if I'm pronouncing your name wrong, but yeah. So excellent update on fetal surveillance, and especially in our part of the world, South Asia, where diabetes incidence is going up. And as you rightly pointed out, that those who are already diagnosed and are on are euglycemic are not the dangerous ones. It is the ones who are undiagnosed. So your guidance is excellent, and especially we have to be careful about the number of tests we do, the expense involved, etc. And thank you for that guidance and the importance of testing in the first trimester, and then the OGTT 75 grams, the being careful about the stillbirths and fetal monitoring in the third trimester. So what you have pointed out, using the fetal movement counts, I think that's one of the simplest things we can do, doesn't cost anything, and can be easily followed, as well as, I do rely a lot on the Doppler testing and presence of end diastolic flow. And that does help us guide a lot. So all in all, your summary is excellent. Thank you very much for your update.
Thank you, ma'am.
Thank you.
Dr. Farhana.
Yeah. Thank you very much. I think the presentation of Dr. Aparna, it was really excellent. And it was sort of an eye-opener for all of us. I would like to mention that as you went through, you first mentioned about the goal, that is we want to make the fetal journey safe. And then you went to key messages. And your key messages, the first was the surveillance in the first trimester, then you went to the second trimester, then you talked about the large for gestational age babies. And after that, and then you talked about the stillbirth. So one thing I want to, in this audience, my way, and lastly, you mentioned that when you were just finishing, you mentioned that there will be the important is that if it is very good control, then still we could go about after 32 weeks. And if it is well controlled, we just follow. And if there is a woman is on insulin or on the somewhat it is on oral diabetic, anti-diabetic, in that case, we have to be very, very rigid. Well, my comment is that when we talk about fetal surveillance in diabetic women, we divide the diabetic women in women who had previously diabetes and those who are GDM. So we know that GDM develops after 20 weeks. So in those cases, it means that the fetal congenital malformation, there's less risk of congenital malformation in these women because of the GDM. And you have very rightly mentioned that there is a risk. We should remember that in the first trimester also there will be the level, aneuploidy, what is the aneuploidy risk and what is the level of the GDM. We should also see to that. So I think that was the very important thing. And my take-home message would be that when we divide women into the who had diabetic from before and those who are developed who have GDM, we should remember that these two group of women, although GDM is GDM, but the risk is more in case of women who embark on pregnancy. Sometimes they don't even know that they have. We don't even know that they had the diabetes and find that they are high blood sugar level. That is the most important thing when there's a risk of the fetal anomaly. And then we go on to the individual level, which you mentioned. And I also think that kick count, there is a lot of confusion about the kick count, and that should also be streamlined so that we obstetrician and also the rising obstetricians also know how to go about the kick count and the surveillance. And before finishing, I would just like to mention that your last slide, which was on the just specific on weeks, that was really very nice. And I think if people stick to it, then the surveillance would be very good. Thank you very much.
Thank you, ma'am.
Thank you. Thank you, respected chairpersons, Dr. Farhana, Dr. Sadia. Thank you, Dr. Aparna Sharma. It was indeed a great presentation. So quickly, we move on to the second part of this webinar, and which is on maternal surveillance and management of GDM. And the speaker is Dr. Gorakh Mandarupkar. And for this, I would love to call upon the chairperson, Dr. Laila Arjuman Banu and Dr. Purdorji. Dr. Laila Arjuman Banu is from Dhaka, and she's the chief consultant and head of the Department of Gynae Lab Aid Specialized Hospital, Bangladesh, and President Bangladesh Perinatal Society. She's been the Secretary General Gynae and Gynecological Endoscopy Society of Bangladesh, Deputy Secretary General Federation of Asia Oceania Perinatal Society, and has held many positions of Treasurer in Bangladesh Menopause Society and Fertility and Sterility Society, and past President of Obs and Gynae Society of Bangladesh, and past Vice President of South Asian Federation of Obs and Gynae. You're so much to your credit, ma'am. You are welcome on this platform. We are honored to have you. Our second chairperson, Dr. Pur Dorji from Bhutan. He's the head of the department, His Majesty's Kidu Medical Unit of Bhutan, Editor-in-Chief, Bhutan Health Journal, KGU MSB, Professor of Obs and Gynae, KGU MSB, and Subspecialist in Maternal Fetal Medicine, JDW NRH Bhutan. So over to chairpersons for introduction of the speaker and subject. Over to you, ma'am, Dr. Laila.
Yeah.
Yes, Dr. Laila.
Yes.
Yes, ma'am.
Can I see the CVs of the speakers?
Yes.
It is not available.
Please put up the CV of Gorakh, sir. Yes.
Yeah. Thank you very much. Dr. Gorakh Manjupatkar, he is the gold medalist, Pune University, Secretary, Dystocia India Association, Member Task Force, National Policy on PPH, Government of India, Member Task Force, National Policy on Maternal Near-Miss Mortality, and Member National Inspection and Monitoring Committee. They drafted FOXI ICOD Dystocia guidelines on hypertension in pregnancy and developed HDP Dystocia score screening tool for screening preeclampsia, and developed two medical Android apps, that is HDP Dystocia score and Cross 11, that is anemia in pregnancy, and 4 books he has written, 12 publications, more than 600 lectures. I think he has so many commitment with the dystocia, so he is the right person to speak in this session. Thank you very much and welcome.
Welcome, Gorakh, and we welcome Dr. Yusuf, who has just joined from Operation Theatre. And if you don't mind, Gorakh, we can take one comment from Dr. Yusuf.
Please.
Dr. Yusuf is Secretary General of CEPHOG. Can we have his CV? Yes. So he is Secretary General CEPHOG, Professor in OB-GYN in Rashid Latif Medical College, and General Secretary of Society of Gynecological Endoscopy, Scientific Secretary, IVF Society, Pakistan, and special interest in high-risk pregnancy and reproductive medicine. A very, very cooperative and a motivating person for doing all the programs. So it's a pleasure to have Dr. Yusuf. Kindly give your address to all.
Thank you, Dr. Sadhna. It's always a pleasure to be here with all of my CEPHOG family. And I would like to appreciate you and as well as Dr. Rajpant to taking this committee to another level and talking about this diabetes. Diabetes, as you all know, is one of those diseases, if you kind of get it controlled, then there is no turning back. But if it goes out of hand, then it plays an havoc. Either you're pregnant or you're not pregnant. And if you kind of get it controlled and the babies, they come out to be happy, live and thrilling, then I think that's one of the best things we can do. I'm so sorry I got stuck up in one of my surgeries, got delayed, but it's always indeed a pleasure to see all of my friends. Hopefully we'll learn more. My only point is that whenever we talk about diabetes, please do consider that we are a low resource countries. Yes, we do need Dopplers, we do need everything else, but in places like even Pakistan, periphery, Bhutan and other places where it's not easy for the patient to come in so quickly or so regularly for our antenatal checkup. So we need to kind of focus on all these things so that they can also be the majority of them, we can benefit that. So it's indeed a pleasure. I just had the last glimpse of the last talk, which was extremely excellent and it was kind of eye-opening, and let's hope it continues like this. So it's indeed a pleasure to be here and good to see you all and stay safe.
Thank you, sir.
Thank you, sir. Over to Dr. Gora. You can go ahead with your talk.
Am I visible and audible?
Yes, sir.
Yes, sir.
Right. So good evening, all of you. And at the outset, I thank Dr. Sadhana Gupta, who invited me in this prestigious webinar. I thank President and Secretary General of the SAFOC and Dr. Amrita as well, and especially the chairpersons who has given the good words about me. Thank you very much. And I will be dealing with a very important part, and that is maternal surveillance. And Dr. Sadhana has given me the task of management of complication in GDM, and with special reference to diabetic ketoacidosis. So because in this 25 minutes, I will try to give the justice to the topic given to me. Why surveillance is essential? Actually, for both the diabetic mother and her fetus, the risk of adverse health outcome, it correlates with the maternal glucose levels during pregnancy. And even a large RCT has shown in ADA that when we do the intensive diabetes management versus the standard care, then it has shown that the rate of serious perinatal complications, it was reduced from 4% to 1% with the treatment of GDM, and improvements in the maternal health-related quality of the life. So it is very clear that the surveillance helps to reassure the obstetrician and avoid the unnecessary premature intervention. Already Dr. Aparna has covered the fetal surveillance part, so my job is very easy. And purposefully in surveillance, I have included these things after so many things that medical nutrition therapy, then the self-monitoring of the blood glucose, exercise, gestational weight management, screening prevention for preeclampsia, and keeping eye on retinopathy and nephropathy. Somebody may wonder that why he has included here the MNT and exercise in this. But the purpose is, again, if we consider this in surveillance itself, then probably with the help of the patient, after telling him so many things, how easy, I will just come in my talk later on, then we will realize that yes, this is very important. We already know that MNT, that all women should receive the nutritional counseling. But when I think of surveillance, why I am giving this, it is because we must give some time that what they are eating, what are their concepts, because it is very important thing that though we are giving them the carbohydrate restriction or control balance meal, at the same time, the adequate calories and nutrients for the appropriate gestational weight gain, whether they are taking or not, that must be seen because that is very important. Individualization of nutritional assessment and calorie requirement with distribution. Though we are seeing towards this MNT as a part of treatment, again I am telling that the individualization of nutritional assessment is very important, because depending upon the weight, depending upon the body mass index, one must understand that what is the need of the lady, and depending upon that, we have to individualize the diet. Again, the body mass index or the percentage of desirable pre-pregnancy body weight, optimal pattern of weight gain during pregnancy, that's very important. And if we keep eye on that, depending upon that, definitely we can help her to select the carbohydrates carefully. Rest all the things, we all know that how to spread the carbohydrate food over 3 small meals, 2 to 3 snacks each day. Complex carbohydrates, they should be preferred over the simple carbohydrates, because the sweet cake, pudding, sweet biscuits, pastry, juice, soft drink, chips, etc., they are the simple sugars which are going to increase our worry. We should tell them regarding the ways to trim the fat from the diet. And it should be the part of our surveillance that how the food preparation is going on. Actually, use the less fat in cooking and avoid frying of the foods. A simple advice. We are telling them what they are eating. We are telling them to keep the notebook, because as just now Secretary General Sir has said, yes, we are the low resource countries, and for each and everything, we cannot go to the hospitals or we cannot go to the consultants for each small advice. Using low-fat dairy products in place of whole milk, choosing low-fat snacks, using lean meat in place of red meat. A simple things, definitely they can help us. Regarding the proteins, we must tell them what are the sources of the protein. At least 3 servings of the protein foods are required every day, and whether they are taking should be the part of our surveillance. The second is SMBG, and that is very important thing, self-monitoring of the blood glucose. We all know that that is the main surveillance actually, that optimal serum glucose control, it is the key to successful management of Jdm, and fasting or pre-breakfast level of less than 90 and postprandial of less than 120 should be our goal. Many a times, I may be wrong, but I have seen that whenever such patients, they go for the management in the court of physician, then we have seen that the tight control of the sugar is not that much achieved, because they say that, okay, till 140 and the non-pregnant level, etc., they are happy. But one must understand, as an obstetrician, baby is still inside, and we must keep the fasting level less than 90 and postprandial level 120. And for that, the daily self-monitoring of the blood glucose, it appears to be superior to the less frequent monitoring in the clinic. At least weekly monitoring should be encouraged instead of not doing at all. And if self-monitoring is not possible at all, then only laboratory venous plasma glucose has to be estimated. What should be the frequency? Ideally, monitoring blood sugar depends on the settings and also if patient is on insulin. Usually, the 4 tests for a diet-treated cases, that means 1 fasting level and 3 post-meal levels, they will suffice. Even once in 15 days, WHO also says that even once in 15 days, this much monitoring will suffice when patient is only on diet-treated. If patient is on insulin treatment, then ideally 6 days, 1 before breakfast and 1 in night before bed, and 1 fasting and 3 post meals, all those 6 days. But practically, really it is very difficult. So 4 days on any 2 days of the week, and especially before the day of the visit, if she comes, and if she comes with a notebook in a proper manner, what we are telling to our patient, daily what she eats, she has to write. And another thing, daily the dosage she has to write, and even the SMBG level as well. So in initial part, till the levels of the insulin are properly managed, then she has to do all these things, and it is very easy. Before giving insulin, one must understand that we have to give her an appropriate meal plan, because probably that insulin is going to cause hypoglycemia. Incorporate safe physical activity. Self-monitoring of the blood glucose by the patient must be taught to her. Self-injection and adjustment of insulin by patient if she is well enough educated, otherwise that part will be on us. To make her learn of hypoglycemia. To develop the techniques to reduce the stress. To keep watch on ketosis. Avoid the smoking, and to check the lipids and vasculopathy to avoid the macrosomia. Already Dr. Aparna has shown that when the blood glucose levels are on higher side, if there is persistent hyperglycemia, definitely it is going to lead to the vasculopathies, the placental problems, later on macrosomia, and almost all the complications. Maximum of the complications of the diabetes, except DKA, they are related to the macrosomia. Even HAPO study demonstrated a linear relationship between maternal fasting plasma glucose, even oral GTT of 1 hour and 2 hours with birth weight about 90th percentile. So infant adiposity estimated by skin fold thickness exhibited a similar strong linear relationship with maternal glucose. The next part will be exercise. Though it comes in management, again, it should be the part of our surveillance that whether she is doing the at least 30-minute gentle exercise, at least 4 to 5 days in a week. And in that, again, the advisor must know the women's pre-pregnancy exercise routine, and depending upon that, the way how to plan or design the exercise. Appropriate exercise will be walking or stationary bicycling. They should be taught to count their heart rate, and given that what is healthy for them and their fetus. And in addition, they should be taught to evaluate themselves for uterine contractions and to stop exercise immediately if they occur. Also, women should understand that contraindications to the exercise include vaginal bleeding, placenta previa, cardiac disease, severe hypertension, malpresentation, IUGR, and the morbid obesity. Gestational weight management. Again, why he has included this in, again, surveillance, because if women knows, if the obstetrician knows, what is my patient, if she's underweight. In underweight women, a total gain of 12 to 18 kilogram must be designed, and depending upon that, we have to discuss the diet as well as other plans with her. With normal weight women, 11 to 15 kg weight gain. With overweight women, it will reduce to 7 to 11 kgs. And in obese women, it may come down to 5 to 9 kgs. But at the same time, we have to see that though we are telling her regarding the diet, the sufficient energy for the baby growth, that must go. But higher gestational weight gain, we know that it is associated with increased risk of Jdm. And that's why purposefully this weight gain I have included even in maternal surveillance. Screening for preeclampsia, again, yes, we all know that, as Madam has rightly said, our South Asian population is almost 11 times high risk to develop diabetes as well as hypertension during pregnancy. As Secretary General Sir has rightly said, we are low source countries, and that's why I am giving here, and we all have agreed that in spite of doing all those markers along with Doppler, along with many factors, it is better to do the clinical risk-based screening. And that's why personally myself, I have designed this HDP Dystocia score, which was modified by then Dr. Sanjay Gupte, Dr. Suchitra Pandit and the team, and it is accepted in the Indian guidelines. And soon I'm approaching to WHO, and now here I'm appealing all the SAFOC countries as well that please go through this HDP Dystocia score. It is already an Android app, and it is just a clinical risk-based screening for the hypertension in pregnancy. It's a simplified dynamic feasible quantification for the effective screening of HDP. Now, the second part of the talk is maternal complications of Jdm. There are so many: polyhydramnios, preeclampsia, prolonged labor, obstructed labor, C-section, uterine atony, PPH, infection, progression of retinopathy, and diabetic ketoacidosis. Madam Sadhana has informed me to mainly give attention on diabetic ketoacidosis. We all know in pregnancy, diabetic ketoacidosis is a rare, but it is potential life-threatening condition for the mother and fetus, and it tends to occur later in pregnancy, and it is more common in patients, especially, as Madam Rihanna said, that in pre-gestational diabetes than with Jdm. But the obstetricians should be aware of the events that can trigger the diabetic ketoacidosis in pregnancy, like infection, the usage of beta-mimetic drugs, then the antenatal corticosteroids, if they are given without proper monitoring and without proper maintaining the sugar level. The prompt recognition and aggressive treatment of this condition, they are essential in order to reduce the perinatal mortality and morbidity. This is classically actually characterized by uncontrolled hyperglycemia, acidosis, metabolic acidosis, and ketosis. Though rare, but yes, it is happening in 1 to 3%. Especially, it is common in patients with type 1 diabetes, but yes, again, it may affect with type 2 even. Again, there are certain physiological changes which are taking place, especially in the pre-gestational diabetes, which are more prone to take that lady to diabetic ketoacidosis. How? We all know pregnancy is a state of insulin resistance created by the hormones. Moreover, in pregnancy, there is an accelerated starvation because glucose is readily absorbed by the placenta. So increasing lipolysis and acid-base state of pregnancy is compensated respiratory alkalosis, which results in decreased buffering capacity. So moreover in that, if there is a diabetes, then yes, there is a problem. It's a state of inadequate insulin action. So that is perceived as hypoglycemia at the level of target cells. So there will be reduction in the glucose utilization at peripheral tissues. So will be increase in gluconeogenesis, increase in hyperglycemia and ketogenesis. We all know osmotic diuresis leads to hypovolemia, electrolyte abnormalities, acidotic state. These are the predisposing factors of the pregnancy. I already quoted about them. And these are the precipitating factors like MSCs, infection, trauma, stress, failure of insulin regimen, either by patient or the dose, corticosteroids, which are used without monitoring, beta-mimetics, again, without monitoring. All these lead to secretion of glucagon, reduced insulin, high insulin resistance, reduced glucose supply of the cell, leading to all these cascade of reactions of, as already I have discussed, hyperglycemia, metabolic acidosis, ketone formations, alternative energy metabolic pathways, they will be in trouble. And it will lead to the signs and symptoms like malaise, nausea, vomiting, abdominal pain, polyuria, polydipsia, weakness, tachycardia, hypotension, ketonic breath, we all know. Even patient may present with altered consciousness. We may find that patient is probably hypoglycemic, but no, here patient will be in ketosis. The laboratory features, hyperglycemia, acidosis, low bicarbonate, then serum urine ketones, positive renal dysfunctions, even serum levels of potassium, often they may come normal, but if we calculate in a proper way, total body potassium will be reduced. Coming to the last part of the talk and of this complication, the management, which is very important. Here, three things are very important. One is fluid therapy. Second is insulin therapy. And third is the electrolyte, correction of the electrolyte imbalance. Fluid therapy. We must take into consideration that probably the estimated deficit water is almost 100 ml per kg, which comes to 4 to 10 liter. First 24 hours, we have to replace by any cost 75% of the fluid, and which will be in the form of 0.9% normal saline. So maybe first hour 1 liter, then again in coming 2 hours 2 liters, and subsequently we have to use the half concentration. That means almost 0.45% of the normal saline, that is 250 ml per hour. That is a balanced salt solution. And the remaining 25% of the deficit will be replaced in coming 24 to 48 hours. Next is insulin therapy. We all know, I'm not going in the details, but yes, because many of such cases, they will be managed with physicians, with endocrinologists, in ICUs. But yes, we, at least as an obstetrician, we must know that initial bolus of 0.1 unit per kg. Then later on, we have to adjust. If the levels are not reducing, then we have to increase slowly. And once the patient is orally tolerant, we have to give this infusion. And later on, the routine subcutaneous therapy must be instituted once the patient is orally tolerant. The last part is hypokalemia. We have to manage with KCl or calcium or potassium phosphates if there is associated hypophosphatemia. In bracket, I have written bicarbonates. Yes, usually in other acidosis, bicarbonates are used, but here in diabetic ketoacidosis, usually bicarbonates, they are not required. Probably it is a large slide. The timing of delivery, actually, there is a separate lecture on that. But here, related to this complication, we must understand that cardiotopography reveals the decreased absent variability, acceleration, late decelerations. Other features of fetal biophysical profile, they may be abnormal, and Doppler studies could show the transient signs of redistribution. Some of the fetal effects of DKA may only be transient and reverse after the treatment of the mother. The timing of the delivery must be individualized based on gestational age, maternal and fetal responses to therapy, and emergency cesarean section before the maternal stabilization should be avoided, because taking out the baby is the treatment in this case. But here, the maternal stabilization and later on the cesarean section, if required for obstetric indications, it will be okay. Otherwise, it could further aggravate the maternal condition. So take-home message: number one, universal screening for the Jdm is to be followed, because our South Asian population is almost 11 times high risk to develop diabetes in pregnancy. Medical nutrition therapy must be individualized. Again, it must be included in the routine part of the surveillance, because what she is eating, how she is preparing the food, that will be very important. Sometime if we give, definitely it is going to help us. Proper energy intake should be encouraged. Strict control of blood glucose level is the key. Precipitating factors of decay must be avoided. And while using the beta-mimetic drugs, antenatal steroids, they are not contraindicated, but while using them, the blood glucose levels must be monitored and controlled. So thank you very much. Again, I have stuck to the time, and I again thank Dr. Sadhana ji for giving me this opportunity, and all of you for patient listening. I hope what Dr. Sadhana has kept in mind regarding my topic, I have given justice to it. Over to you. Thank you very much.
Thank you, Dr. Gorak. It was a wonderful talk, and you stuck to time. That was wonderful. Over to chairpersons, Dr. Laila and Dr. Purb. Please give your expert comments. Chairpersons? Yeah, Dr. Purb.
Very good evening. Greetings from Bhutan to all the learned faculty there. I think Dr. Gorak has highlighted very well issues with the maternal management. It is always a challenge that we, the clinicians, tend to go after our medication protocols and inconvenient recalling frequent visits of the patients. And we actually fail to give them a very clear message about the nutrition therapy component. And this is also a problem in Bhutan, because we also fail to understand, because of the different levels of economic status of the patients, that what diets do they eat. One advice cannot actually be a cross-cutting. So there's a huge area of to improve in the maternal management with diabetes, is to give them a customized advice on the affordability-based plan on the dietary habits, which is very important. I think he has highlighted that very well. And the rest, we all have heard clearly, has highlighted all the important ones, and including the DKA, which is though rare, but I think with the population of diabetes coming, pre-gestational diabetes population is increasing so fast. So we will definitely have higher and rising incidence of DKA. So we have to manage it, because we will have instant death with the mother and feed and baby inside at any point of time. These two are the very good ones he has highlighted, and the rest he has done justice. Thank you.
Thank you, sir. Over to Dr. Laila, please, madam.
Thank you very much. I first acknowledge Dr. Sadhana to include me in this very important session, and also the Suffolk President, Professor Rohana, and Secretary General, Professor Yusuf Latif Khan. Sorry, my camera is not working. Dr. Gorak has nicely described the maternal surveillance. Actually, he has very clearly explained his topic, and especially maternal surveillance and management of complication in Jdm. And amongst them, it is very important that the surveillance, if the surveillance is done, then the complications reduce from 4% to 1%. This is very good information. So I think he has nicely said it. And the points are, the mother should select the carbohydrates, less fat, and optimum serum glucose is the key point. Actually, previously we know that there should be some hyperglycemia to tackle the mother's condition, but nowadays we have seen that as much as blood sugar is controlled, the outcome is very good. So the 4 tests should be done 2 days of a week, he has explained. And for insulin, those who wants to take the insulin or their condition permits insulin, there is some criteria should be followed, like and the mother should know the information about the hypoglycemia. It is very important because hypoglycemia is very adverse effect on mother and especially the fetus also. And exercise 30 minutes, gentle exercise 5 days, he has mentioned. And HTP dystocia score, very nice. And I think he has developed and we should follow it strictly. And to avoid the diabetic ketoacidosis, Dr. Dorji has already said, and details should be known to especially should be informed to the patient, and she should know the signs symptoms of diabetic ketoacidosis and the management by fluid therapy, insulin therapy, and treatment of hypokalemia. So universal, and the take-home message is universal screening, medical nutrition therapy, strict control of blood glucose, and diabetic ketoacidosis. One important thing, I think the patient should know the homemade the blood glucose monitoring. She should know. It is very important because it is not possible, especially countries like ours, that the mother will leaving her 4 to 5 children at the home to go to the health center repeatedly. So I think she should know how to what are the signs symptoms of hypoglycemia and how to monitor the blood sugar levels. I think it is very important. So I congratulate Dr. Gorak for his very excellent presentation and very important information. I think it should be known to the patients. And thank you again, Dr. Sadhana, for repeatedly knocking me. Thank you very much, all the hosts for this webinar. And I think it will be a very good webinar for our juniors and the other doctors. Thank you very much.
Thank you, ma'am.
Thank you. Thank you, Dr. Laila. We would have loved to see you, but unfortunately, your camera is not working. Thank you, Dr. Pur. And thank you for your precious time, Dr. Gorak. And now we quickly move on to the third part of the webinar. And it is indeed a dilemma: when to deliver, how to deliver, the diabetic patient. So the topic is obstetric decision and labor management in GDM. And the speaker is Dr. Lubna Hassan from Pakistan. And for this, I would love to call upon the chairperson, the co-chair of NCD committee, Dr. Sadhana Gupta herself. May I have her CV, please? She has been introduced. She is the co-chair presently of CEFOG NCD committee and has been our vice president, and many publications and medals to her credit, many honors. Next chairperson, please. Dr. Ganesh Dangal is a highly qualified faculty from Nepal, and he has fellowship in urogynecology, gyne-oncology, and minimally invasive surgery. He's the deputy academic director and IRC chairman at FEC Nepal Kathmandu Model Hospital. He's president, Nepal Society of Obstetrics and Gynecology. He's the chief editor of the Journal of Nepal Health Research Council, peer reviewer and editor of J. Acta Obstetric Gynecologica Scandinavia, and he has many awards and honors to his credits and received national and international awards like Soma Award, Ronast Award, FIGO Fellowship, FIGO Chin Teen and Su Fellowship, ASCO Awards, etc. He is always invited as national and international faculty to various conferences and has more than 200 publications in the national and international journals. So over to chairpersons for introduction of the subject and the learned speaker, Dr. Lubna.
Thank you, Amrita. And with the fetal and maternal surveillance now, it is a critical time that when to deliver and how to deliver. And always there are questions from the patient and family, and there are many doubts and the apprehension on the obstetrician. And when we have gone through the journey of 9 months or almost 9 months with the patient with GDM. So for enlightening is on this like gray areas, it is our pleasure to invite Professor Lubna Hassan, who is consultant obstetrician gynecologist and the founder Women's Hospital Peshawar, Pakistan, has been Vice President SAFOG 2019 to date, member FIGO Committee for Women in Crisis, founder Director Women Health Intervention and Development Initiative, WHO Technical Expert Group on current many guidelines and classifications like Robson classification and MDPSR. And she has been president of the Society of OB-GYN Pakistan from 2010 to 2013, and at head of the department in OB-GYN at Hyderabad Medical Complex, Pakistan. A very warm and a learned person. It's pleasure to have Dr. Lubna, and kindly go ahead with your presentation.
Thank you very much. I'm trying to share my screen. Okay.
Yes, ma'am.
Can you see my screen?
It's visible now.
Okay.
Yes, ma'am.
So thank you so much. I'm really grateful to the organizers and of course, Dr. Sadhna, who thinks about me just as I do. We've had a very good time together in various parts of India, which we've enjoyed, and I hope to entertain you here in Peshawar someday. But whoever sort of chose to make me speak after these two wonderful, really well-read, eloquent young speakers, Aparna and Gorak, were not my friends. But they've made my life easy in the sense that if they've done their job well, then labor, the woman will just breeze through labor. And that is what diabetes is. It's a spectrum where you just do masterly inactivity in labor, or you need the whole hospital to come and help with ketoacidosis and God knows what all. And so it cannot be taken lightly. I've been asked to talk about obstetric decision and management of GDM. Now, I am a very old-fashioned person who does not like to compartmentalize things, especially when they are difficult to diagnose. GDM is a diagnosis in retrospect. So if you're managing a woman in labor, I think a lot would depend on her level of hyperglycemia. And so hyperglycemia in pregnancy, I think, is something that we need to get used to talking about. So obstetric consideration, and this has been amply said by both, that the goal, of course, of fetal surveillance and planned delivery in women with diabetes is the reduction of preventable stillbirths. But as was very beautifully explained by the first speaker, stillbirths are not always avoidable, because some of them can occur even before you actually start to do your surveillance. And even if we find out, we don't know the causes quite often. But however, because over the years, stillbirth rate and all the other complication rates have decreased, it is still recommended by most people to continue with fetal surveillance, just like you do for other high-risk pregnancies. Now, the most important, I think, issue in GDM or, hyperglycemia and pregnancy is to get that multidisciplinary team. It's not always easy to find that team, but I feel that one of the most important issues at hand is not just when to deliver, the timing, and how to deliver, the mode, but where to deliver. And I think this, if we pick them up early, then they must be in the best hands, and you will know why so we need this multidisciplinary team. It is now no more the job of just the obstetrician. And of course, the main issue, I feel, is the target to bring this thing between 4 and 7 millimoles, or 72 to 126 during pregnancy. In labor, it's even stricter. All right, so if you look at the main two issues is impartum care, the timing and mode of birth. And I looked at all this, there is some, that there is a lot of evidence from all over the world. Everybody and his granny is working on diabetes. But there are some organizations who are credible, and this bit of sort of information to discuss the timing and mode of birth with pregnant women during antenatal appointments, especially during the 3rd trimester. This is coming up over and over again, because diabetic women, even if they're GDM, even the fact that you're calling them again, they may not be able to afford it. They may not have the time. They get very, very anxious. So it's very important to involve them, and then you will get a more compliant and a more adherent patient to whatever you're telling her to do. And then, of course, as I told you, the main thing is the glycemic control, to prevent neonatal hypoglycemia. Again, there is evidence from NICE and SIGN, the Scottish group, and that at birth, how to prevent or look for neonatal hypoglycemia, and then the initial assessment of the baby. So basically, earlier onset and or more frequent health survey recommended in those at high risk, GDM that is poorly controlled or associated with comorbid conditions. So we've talked about the acceptable methods even more than what I am saying, but these were all the acceptable methods. But that is because we have to make a decision regarding timing of delivery. We never want to deliver a baby more than before 40 weeks. But when we have to, then we have to balance the prevention of stillbirth and a possible decrease in the cesarean section rate. And I'll be talking about that a bit, because cesarean section rate is rising in the diabetic population. And this has to be weighed against the likely increase in neonatal complications. So you look at the maternal risks, and they've been talked about during pregnancy, but during labor also, there is a real chance of a diabetic mother going into preterm labor, either iatrogenically or pathologically. Operative deliveries are common because of the big baby, and we talk about that. Infection, increased risk when poor control of diabetes and obesity. So there is the infection. Thromboembolism, again because of obesity. End organ involvement in type 1 and type 2 diabetes, and GDM associated with hypertensive disorders. So these are all the maternal risks, and if they are there, then obviously all the alarm bells and the alerts go up. And some of them and many of them can be prevented and should be prevented during pregnancy. The fetal risks, large for gestational age or actual microsomia, which of course, the most dreaded shoulder dystocia, birth traumas, fetal acidemia, stillbirth. She talked about, Apurna talked beautifully about stillbirth. And then of course, neonatal hypoglycemia and all the other deficiencies, hypos that occur, and respiratory distress, which although decreased, still is quite high in the scoring when you talk about fetal risks. So you have glycemic care goals, you have maternal care goals, and you have fetal care goals during labor or during delivery. So those women who are well controlled on just diet and exercise, or even just on oral, monitor blood glucose with a glucometer, and this can be done every 4 to 6 hours. An anesthetist assessment should preferably have been done in the 3rd trimester, but if she's just walked in, then especially if she has comorbidities, then an anesthetic assessment, because you never know when things can go wrong. And of course, there has to be continuous surveillance in active labor. But if that is not possible, because I know in some of our hospitals, then even if it's not continuous, you can still, the fetus needs to be surveyed. Women on insulin monitor and titrate as per sliding scale. And we'll talk a little more about that, because there are very fancy ways of monitoring and dispensing insulin now according to various charts. And of course, for the maternal, you will avoid starvation, ensure adequate hydration, and avoid ketoacidosis. And for the baby, careful management of the 2nd stage in view of increased risk of shoulder dystocia. If antenatal non-compliant, now these are women who might just walk in and for the first time in labor or in the 3rd stage. And then you do your spot blood sugar and find she's diabetic. Well, then she should be treated as the insulin group. And of course, all of them should have a partograph during labor. Now, the maternal goals, I briefly told you, but additional vigilance is required for women with comorbidities, because diabetes itself does not occur quite often. It does have comorbidities. So standard antibiotic prophylaxis and pneumatic compression device, if there's going to be a cesarean section, all the normal things that we do for high-risk groups, we should do also in diabetic patients during labor. Postpartum heparin can be given based on and of course, ambulation are required for thromboprophylaxis. Now, the active management of labor is recommended. Many people are not doing active management anymore in many of the routine cases, but in this case, because failure to progress is more common in these women, which may be due to a larger baby or an awkwardly lying baby, but this had lowered the threshold for cesarean sections. And especially in association, these are studies that have shown that especially in association with nulliparity and those that are using insulin and those that have gestational weight gain, and all three together have raised the incidence of cesarean section in the diabetic woman. And so to allay that, the active management of labor is encouraged. When diabetes is associated with end organ complications, a baseline reevaluation in early labor or prior to planned delivery is required, because throughout pregnancy, she may be coming after a week, and these things are ongoing and things may have changed since she had her last antenatal visit. So for instance, if the blood pressure control, avoidance of fluid overload is required for those with preeclampsia. Ideally, all women with hyperglycemia and pregnancy should be seen by an anesthetist, as I said before, during the antenatal period and well before labor, so that we know that the anesthetist is on hand. The fetal goals, of course, macrosomia, shoulder dystocia, and birth injuries. I mean, you think diabetes and you think of that obese, chubby baby that Gorak just showed in his presentation. So there is a higher risk, of course, of large for gestational age fetuses and for macrosomia. The fetal size evaluation, I'm glad that now they're doing more detailed scans, and you can actually, are closer to the actual weight, but there are limitations in predicting large for gestational age through ultrasound. Hence, intrapartum periodic clinical reassessments. Now, what do we mean by that? It means that just because the ultrasound has told you it's a big baby, or the ultrasound has told you it's a small baby, does not mean that you do not have to examine the woman abdominally and when you're doing a pelvic examination to assess just how large the baby is clinically, whether it is coming down nicely, or so on and so forth. So your clinical assessment, which doesn't cost a lot of money but requires good training, must continue to assess and look for macrosomia. So retrospective analysis gives reassuring data. Now this was because I'm really working to optimize cesarean sections, and this was one area that we found that we are having very high incidence and prevalence of cesarean sections. But various studies have now shown that in a skilled obstetrician unit that is in a well-equipped facility, where regular drills are done and they have the necessary staff, vaginal deliveries are quite easily done, even if complications occur, with little detrimental effect to the baby. So that is something that even if we don't have a lot of money and we don't have fancy things to do, we can at least sharpen and develop our skills. Warning signs of shoulder dystocia. I don't know how much time I have, but I'll just quickly go through that because it is so important. Slow progress in the first and second stages of labor. That is why a partogram is very, very essential, because if you find, then there is an alert and you can look and see what's happening. There is the head bobbing sign, the head coming down during active pushing and then receding in between contractions. The turtle sign and failure of descent with gentle downward traction. Now, it's extremely important because when you are training and the juniors tend to pull, when the head comes out, they tend to pull on it. And that is something that should not be done with excessive force, because if the shoulders are above the pubic symphysis, you are going to, get more damage and more trauma to the baby by pulling on its head. So you have to go through the maneuvers, and that is why it is important to have these drills and be familiar with these maneuvers. The health system maneuver, this is a long list that I won't go through, but I think it is incumbent on all trainers to ensure that their trainees know exactly what all of this means and how to do it methodically, turn by turn, in a systematic way. Stillbirth, I won't waste more time on it. It's already been talked about, but there is an increase in stillbirths in between hyperglycemia, with a significant increase after 39 weeks. There is room for induction of labor here. Studies have reported a 5 times higher risk for stillbirth in the presence of diabetes, and of course, most of it with type 2, but because it's also has comorbids and it may have advanced maternal age with hypertension, but there it is, the stillbirths are on the rise. Respiratory problems, although they've really reduced over the years, but we know that in the non-diabetic woman, pulmonary maturity occurs between 34 and 35 weeks around. In the diabetic pregnancy, on the other hand, it might take as long as 38.5, which is why when we talk about when to deliver, you should be prepared when you're trying to deliver a diabetic woman, and then by cesarean section before 39 weeks. The great preparation needs to go into that. So of course, then you have polycythemia and the reasons why you have all of these, but I've just listed them so that you look out for them, because tests can be done if they are suspected. All right, so it's universally accepted tight glycemic control is necessary throughout pregnancy, and it is more crucial during labor. The monitoring of blood sugars along with continuous glucose infusion has been used for the peripartum management of diabetes in many centers, and it causes less. So continuous glucose infusion is the this thing of choice, but of course, many of us don't use that during labor. The disadvantages of just taking specimens of blood gives you a partial glucose profile because it can miss hyper and hypoglycemia, especially in those patients in whom we have high hyperglycemia and we want tighter control. So maybe perhaps continuous infusions and continuous monitoring is important. Now, insulin management during labor and delivery is important part of care and must be adaptable given the unpredictable combination of the work of labor. I mean, a woman in labor is spending as much substrate and glucose as she would if she was doing intense exercise. So that combined with dietary restrictions, most women, especially those on insulin, are not allowed to eat during labor. And then, of course, the need for operative delivery, there might be a need for operative delivery. So a combination of these three things can be a recipe for disaster if it is not well planned and thought out. So the goal is to avoid maternal hypoglycemia while preventing significant hyperglycemia, which in turn may increase the risk of neonatal hypoglycemia. So that is the conundrum. It's a tight balance, but that is what needs to be done. So women with previously uncontrolled sugars may require, and it depends how much insulin will be needed and how you give it, will depend on women who may require a high dose of insulin during peripartum period in those who are previously uncontrolled. It also depends on the type of diabetes. But again, it depends on the hyperglycemia level as well. But whether it's type 1, type 2, or gestational diabetes, that also will, you'll need to know how much insulin to give. During the latent phase of labor, again, labor has two phases. In the latent phase of labor, the metabolic demands are stable. But when, as I told you, during the active phase, there is increased metabolic demand and decreased insulin requirement, which means especially in type 1 diabetics, their blood glucose sort of almost, they need that substrate because it's almost like they are in, doing rigorous exercise and their insulin requirement may suddenly totally decrease. That's why continuous or very, insulin testing, blood sugar testing is a must. The protocols used may rely on glucose, but what we are looking for in most of them, I mean, it was between 70 and 126, but most studies said that the blood sugar should be maintained between 70 and 110 milligrams per deciliter. So the time and mode, type 1 and 2, no other complications. They can have an elective birth by induced labor or if indicated cesarean section between 37 weeks and 38 weeks plus 6 days. Most studies favor 39 completed weeks or 38 plus 6 days. Consider elective birth before 37 weeks for women who have metabolic order. Obviously, it can be done before that. In GDM, birth no later than 40 plus 6 weeks, that is provided everything else is all right. Consider elective birth before 40 weeks plus say for women with maternal or fetal complications. So it's almost the same. It actually depends on the complications and the hyperglycemia. Now, diabetes should not be considered a contraindication to vaginal birth after a previous cesarean section. That is important to understand, especially in our setup where women have a lot of pregnancies. And if they've had one, they should not be subjected to others for no reason. For pregnant women with diabetes who have an ultrasound diagnosed macrosomic fetus, explain the risks and benefits of vaginal birth, induction of labor, and cesarean section. Again, the woman should be taken into confidence you must look at her parity, look at her age, look at her future, this thing, and then decide what needs to be done. So options for peripartum blood control include algorithmic or one size fits all. One size fits all means what we mainly do, that we make up a sliding scale, this thing, and then we keep on taking blood sugars, and then according to that, we titrate the insulin. But in Europe, they've started now. I read this really interesting article where they've made tables for different levels of hyperglycemia, and then that table is followed during labor and delivery. It's very intensive, and you need to really understand, but obviously the results are better. So you can do watchful waiting, and have a specific threshold at which you would, start the insulin, presumptive initiation of intravenous insulin infusions, or continue if they're already on continuous infusions. During labor and delivery, the goal is to maintain the sugars in the normal range as safely as possible. Increased blood sugars 4 to 6 hours prior to delivery leads to increased rates of hypoglycemia. This is a very important bit of information, because if the blood sugar is high, the maternal blood sugar is high, and within that hyperglycemic state, between 4 or 6 hours a delivery occurs, then hypoglycemia in the baby is definitely going to be there. Continuous monitoring of blood glucose, as I said, during labor may improve the outcome. And during labor, normoglycemia is mostly achieved with short or rapid acting. This is old stuff. I don't think anything is changed in that, except the way that the insulin is given. So in a case with GDM controlled only on lifestyle modification, it is not compulsory to monitor. You can monitor every 4 to 6 hours. But if if that same woman is on insulin, then you would need to monitor 1 to 2 hours. And women with type 1 diabetes, a glucose infusion is mostly required during the latent period, and of course spontaneous. And we talked about that the requirement of insulin may drop to almost zero, and the glucose requirement would skyrocket, which is why we need to give both. So in clinical practice, 6 to 8 units of conventional regular insulin or analog, and I think we've talked about that in the last this thing, but that is how it is normally given. So each center should establish protocols which include blood sugar, blood glucose targets, monitoring, frequency, insulin regimen, and intravenous based on nursing, medical, and whatever staff is available, because things are different. But I think this is like all high-risk cases. This is diabetes is one instance in which we need to sort out our referrals. And surveillance sort of comes in, simple surveillance tools, so we can send the patient to a center where better things can be done. So clinical identification of increased risk of stillbirth should be the target, and the approach has to be individualized, and initiation of weekly assessment of fetal well-being at 34 to 36 is recommended, even in those that you think don't have. Of course, the ones that do have an issue, you would have to start much earlier. Now, preterm delivery, just 2 things about preterm delivery. Usually, it's increased when the blood sugar glucose level goes above 5.8. Beta-mimetic agents for tocolysis should not be given. And if you give antenatal corticosteroids, as the speaker before me said, it could lead to ketoacidosis if you don't monitor them well. And here is a good table that you all should have, that depending on how much insulin the woman is taking in 24 hours, there is a table here of how it needs to be increased on day 1 following the first shot of betamethasone. So spontaneous labor, of course, we've talked about it. You have to be vigilant, continuous fetal monitoring, and depending on the hyperglycemia, you give the insulin. And then we'll briefly talk about elective section. Should be done early in the morning. Again, this is old stuff. If the intermediate acting, she is already on intermediate acting insulin, it should be given at night. The morning dose of insulin should be missed. Glucose monitoring with a fasting sample and repeat every 3 to 4 hours. If the section is not done early enough, check blood glucose 1 hour before planned cesarean time and maintain sliding scale throughout. Now, if anesthesia, especially if general anesthesia is given, if the woman has general, the monitor blood glucose every 30 minutes till the woman is awake, from induction till she is awake, and you give your antibiotics and thromboprophylaxis as required. Now, induction of labor, there is a lot been going on. As always tell my students that the most important bit of information you need obstetrically is the period of gestation and the LMP, the period of gestation, and especially in diabetes, the period of gestation is so very important because you base most of your management on that. So the induction of labor is used and should be used in diabetes, in women with diabetes, because expectant management, many studies have now shown that expectant management beyond about 39 weeks definitely increases stillbirth and all the other problems of shoulder dystocia and even cesarean section. So that is something, especially if they have issues and they're insulin dependent, then beyond 39 weeks or 38 weeks, nobody would sort of do expectant management. Now, immediately post-op, we know that the requirement of insulin shows a sharp decline in GDM, and perhaps you could stop it in type 1 and type 2. It's best to reduce the dose and not to stop it completely. Breastfeeding, sometimes the requirement of insulin can fall drastically. And so you have to be careful and watch out for hypoglycemia. And the postpart, women have undergone cesarean sections, although it's not very clear, but strict control is needed because you know that complications like infections can take place if you don't get good control. How much time do I have, or should I wrap up?
It's over actually.
Oh, it's over. Okay, so I'll just advise initial assessment. I think I'll just skip through all of this.
Yes, ma'am. Postnatal care is to be taken by the other speaker.
All right. So I'll just go to the conclusion. And, basically, you need a multidisciplinary care based on periodically reviewing guidelines. You know, this is something that we really, really need to get, a grasp on. Timing delivery based on individual circumstances, active management of labor, maintaining blood glucose levels, treated as high risk, they should be treated as high risk, the ones with high blood sugars, and the timing and mode of delivery, all this should be discussed with the patient and the women and the family. It allays anxiety and increases adherence. Intrapartum glycemic control involves additional monitoring and must be planned in advance. There has been significant improvement, but I think a lot needs to be done. And together, if we get together, we can do that. So thank you very much. I'm sorry, but I can't even see my own pictures. I just lost this thing of the time. But thank you very much. I'll just stop there.
Thank you, ma'am. Thank you for that elaborate and complete information with all the evidences regarding the management of labor. And over to
something
Chair.
happened I could not see. I was just staring at this thing without knowing the time or getting any feedback. So it was a little bizarre, but thank you.
Yes, ma'am. We could see you, ma'am. And
Thank
it
you,
was...
Dr. Lubna, for wonderful elaboration and with all the storm outside your house.
No, the storm has settled. The electricity is come, so I'm happy.
So very, very, like it is a labor management is a real critical issue when we are really we want to have a balance between high cesarean section rate and the optimized outcome after delivery. So very rightly, you have I think few points you have emphasized very nicely that the optimum blood sugar level during labor is very important. Don't starve the woman, don't dehydrate and maintain the blood sugar level with the insulin or with the hydration. Secondly, 38, 39, 40, but diabetes not beyond 40. Even if it is controlled on maternal nutrition and elective induction around 38 to 39 weeks, especially in South Asia when like it is a good consideration for management of labor. Anticipating birth complications, so prophylactic Mac-Roberts maneuver for every diabetic patient if she is going to deliver, that is also one important, and all preventive measures like active management of third stage of labor for PPH and other things. So under neonatal care, what you emphasize, that is multidisciplinary care. Many times we in a small hospital and in a public health setting, we don't have that like organized multidisciplinary care. What minimum we can have everywhere, that is a good obstetrician, good nursing trained staff, and a neonatologist. So I think that will be the minimum need we owe to our women. And all about this thing, the high cesarean section rate. One thing question, Dr. Lubna, I will like to have, you said general anesthesia. So we usually opt for spinal and the regional anesthesia for all cesarean sections, and even with the GDM. So your comment on it, that general anesthesia is preferred, or yes?
No. Sadhna, you are absolutely right. I think the age of obstetric general anesthesia is long gone. But because the spinal or epidural does not carry the same problems, because the mother is awake and can actually this thing, and even the sort of metabolic issues do not occur in spinal as they do in general. But in case there are circumstances where there is an abruption, or there is the mother does not want it, but in case that a general anesthetic is needed, then and is given, and obviously that is the domain of the anesthetist, and normally they do. Even in my practice now, we are doing almost 100%, but there are sometimes they want to convert it to general anesthesia, or they give general anesthesia. So that is for those that then they need to be monitored more stringently. It's not that it is recommended for diabetics.
Yes. So thank you very much for compiling all the critical issue. And Dr. Before going to welcome Dr. UDP Ratnasiri, Chitra, can you say Dr. Alka Kriplani has joined because she has called me? Dr. Alka, are you there?
Yes, I'm very much there.
So, Madam, it is a great pleasure to have you. Always your presence actually sparks everything. Madam has been introduced, so she is our beloved, beloved teacher, beloved mentor, surgeon par excellence, and all the honors, Padam Shri, Dr. B.C. Rai National Award, and all the post President Foxy, President JC, President AOGD. But above all, she is all beyond post and all the feathers, because she is in our heart and she teaches our hands and brains for in all fields. So we invite Dr. Alka Kriplani to say few words about this SAFOG and CD committee webinar, which we have planned every second Friday under the leadership of Dr. Padam Rajpant, who is chair, and the president, Dr. Rohana Hatullah. So just to make what we are going through about it. So your words from
Thank you so much, Dr. Sadhna, for your lovely, kind words. We both are a mutual admiration committee. But I would like to say some things. This CEFOG is doing such a good work. Dr. Rohana, I have worked with him in AUB committee when he was the chair and I was co-chair. So he looks so simple, but inside he has so much of strength. And he can, handle any situation. And I think that is the reason CEFOG is doing so well under his presidentship. What to say of dear Sadhna? She used to be my vice president when I was FOXY president. And I'm myself from a very small place without so-called godfathers and godmothers. We have reached where we. So I fully understand, Sadhna, how hard you have worked to reach where you are. And you are an inborn leader. So I can't say Gorakhpur is a small place now because Gorakhpur is giving such great personalities to the country. And you are one of them after,
Yes, ma'am.
after Mr. Yogi, who has taught, who has changed everybody's opinion about him, including myself, how effective a leader he is. So you are on the same path. Gorakhpur has, I think, something special. So the wonderful leaders. And what to say of this sweet girl, Amrita?
Oh my God, ma'am. Thank you so much.
She was with me. She's such a lovely person, always willing to spend time for academics. And I really admire you girls from Gorakhpur who have brought the Gorakhpur on the map of FOXY so high, as your chief minister has done on the map of India. And Sadhna, one particular thing, you are always ready. How much time you are spending in academics? I salute that. Not only in a year or two, for so many years. I think tomorrow we both are going to be together again in that ad board meeting where we do lovely discussions. I don't want to miss it. But I have another lecture in Delhi, so I will be joining little late. I'll try my level best. And we will really be, that's upcoming topic. We share our clinical experiences. And before I stop, Dr. Lubna, I enjoyed her lecture thoroughly. And at the end, I would like to, sorry, because I was in deep sleep. So that was the reason I could not join. And the moment I got up, so I must apologize for delayed entry. But you see, it is good, the breather in between the lectures. So I wish you people all the best. I can see all the time, Amrita, such a smiling, lovely face. Amrita, you should also be continuously coming up. I think we from small places should do our work, should speak for ourselves, and how much Sadhna is helping the people in remote areas because they identify with her. And when Sadhna speaks, everybody feels like they are, into it. So I wish you all the best. You people are doing so well. So much of effort, so many webinars. All the best. Thank you for the invitation and sorry for joining late.
Thank you, madam. Thank you
Thank
for
you.
your all loving words and all, like, it is really motivating. It really motivating and inspiring. So thank you. And Amrita, Dr. UDP has joined, and please invite her. Thank you, madam. And I hope we didn't disturb in your deep sleep with my messages and calls.
I'm so sorry. I'm so sorry. The moment I got up, I joined.
Thank you, ma'am. Thank you for the encouraging words. And we would like to hear from Ganesh Dangal. He was a co-chair with you, Sadhna, ma'am.
He has some internet issue, actually. It's not
Okay, fine. So let's move on to the last topic of today. And it is immediate and late postpartum care in GDM by Dr. UDP Ratnasari. For this, I would like to invite the chairpersons on this platform The first chairperson is Dr. Padmaraj Pant, who is the chairperson of NCT Committee of CEFOG, and he is the chief of the Infertility Unit, Department of Obs and Gynae, Tribhuvan University Teaching Hospital. He is also the professor and head Department of Obs and Gynae, Tribhuvan University Institute of Medicine. He is the chairman, Department of the Obs and Gynae, Grandee International Hospital since its establishment, and Chief Department of Obs and Gynae Hospital for Advanced Medicine and Surgery. So, sir, you are involved at so many places. I wonder how you work like this. And the second chairperson is Dr. A.G. Radhika, senior consultant at Delhi. And she has held many positions and national coordinator for clinical research, national corresponding editor, Journal of Obs and Gynae India. She's also a fellow, FICOG, LMIC representative, Guidelines International Network, member and expert reviewer, Cochrane Collaboration, member South Asian Cochrane Network, member Campbell Collaboration, and so many others. She's also the editor of newsletter Narchi. She has won many awards. Recent ones are ICOG Visiting Professor Award 2019, Foxy Korean Award 2019, Foxy Best Paper 2016, and WHO Fellow Advanced Course of Monitoring and Evaluation in Health System. And she has more than 75 publications in international and national journals, and she has edited 2 books. So with all the learned chairpersons, we are on the last talk of today. Over to chairpersons.
Thank you. Thank you, everybody. So next speaker is Dr. UDP Ratnasiri from Sri Lanka. He is consultant obstetrician and gynecologist, immediate past president of Sri Lankan College of Obstetrics and Gynecology, and he is treasurer of CEFOG, chairperson of MFM committee of EFOG, and he is also chairperson of IRC, RCOG, and secretary BOS in obstetrics and gynecology. Dr. Ratnasri, please, floor is yours.
For kind introduction. First of all, greetings from Sri Lanka. I first thank Dr. Rohana Hatpatuwa and Sadhana for inviting me to give this lecture. So I think you all heard about the lecture on, I'll get to the slideshow first. So my talk is immediate and late postpartum care in gestational diabetes mellitus. So you heard what is happening during antenatal period and delivery, but we think after the delivery, everything is over now. It's not. Immediately after delivery, the postpartum insulin requirement decreases dramatically. It's as a result of rapid decrease in the diabetogenic placental hormone levels and result in dissipation of pregnancy-induced insulin resistance. So when the woman has been diagnosed with gestational diabetes, when the baby is delivered, as the placenta production of these hormones decreases, they should stop the blood glucose lowering drug if they are on. But some of them are managed with medical nutrition therapy alone. It is very important, whether it is a cesarean section or whether it is another mode of delivery like vaginal delivery.
Sorry to interrupt, sir. Can you make it full screen?
How can I get it, please? Thank you.
Please click on slideshow, sir.
Slideshow is not
Yes,
getting.
sir.
All right. Okay.
From current slide.
Audio is not very clear.
Okay. Thank you.
And now
Okay.
it's fine.
Thank
Is
you.
it clear for you?
Yes, sir.
Right, thank you. So as I mentioned, whether respect of mode of delivery, the care is the same. So immediately after delivery, like in the other patients, they should start insulin, breastfeeding. So when the woman has been managed with blood sugar monitoring, and when it has come back to normal, before transferring her to the community care, we have to exclude there's no hyperglycemia. And this woman should be educated thoroughly about the symptoms of hyperglycemia, which had been there before sometimes, but continually she should be monitoring about the symptoms of hyperglycemia. And there is a risk of recurrence of this disease condition in the future. So they should be educated that once the blood sugar level goes down, there is another chance of recurring in this future pregnancy. So they should be given contraception, and also they have to plan the next pregnancy with the pre-pregnancy counseling due to this disease condition. So if it is after normal birth or whatever the birth, we should offer lifestyle modifications. If she is an obese woman, she should control the diet, to control the weight, and maintenance of breastfeeding and continue with the exercises. But if she's now, this weight control and dietary measures may not be correctly advised by the postnatal care providers. So if it is an institutional delivery, we have separate clinics like diet clinics, like the nutrition clinic and physiotherapist, and these people can advise them about what is the weight control that they need according to the weight they are already with. And diet and exercise also a very important part. So once they are released to the community, we should offer a plasma glucose test 6 to 13 weeks after the birth to exclude diabetes. So usually most of these women are attending the postnatal clinic 6 weeks after delivery. So that is a good chance for them to attend. And the nice guideline say we should not offer 75 grams 2-hour glucose oral glucose tolerance test, but different guidelines in different regions offer different tests. So there's a variation in the test, but the NICE says offer a fasting blood glucose level. Now, if at 6 weeks, if the fasting blood glucose level is below 6 millimoles per liter, they have a very low probability of having diabetes at this moment. So they should be continued to follow up with the lifestyle advisors, with the lifestyle modifications, weight control, exercise after birth. And they need an annual test to check their blood glucose level to see that they are not developing diabetes. If it is between 6 and 6.9 millimoles per mercury, and they have a high risk of developing type 2 diabetes. So they need more exercises, dietary control, and frequent monitoring. If they are after 6 weeks, if the fasting blood sugar level is 7 millimeters or more, they are already having type 2 diabetes, and they should be offered other tests to confirm this and follow up with the diabetic care pathway. That is, I'm not going to tell you what is it. So as we mentioned, perception of gestational diabetes as strictly a medical complication of pregnancy, the hyperglycemic implications of this diagnosis actually extends beyond gestation. It is not confined to the gestation alone. It should be the lifestyle. Specifically, the beta cells defect that yields insufficient compensation for insulin in pregnancy, both chronic and progressive in nature. So notably, women with gestational diabetes have elevated risk of the consequences of diabetes like renal dysfunction, liver disease, and cardiovascular disease. So they have an elevated lifestyle incidence of cardiovascular disease, even if they don't progress to diabetes. Now, Jdm has been shown to carry a higher risk of cardiovascular disease more than the type 2 diabetes in years to come. So these are the guidance given for the postpartum different is the ACOG referral pathway. So if the fasting blood glucose is above 125, she is diagnosed diabetes and referred to the diabetes management. If it is between 100 and 125, impaired glucose test, so they have to go for the physical activity dietary control. And if there's impaired fasting glucose, to start with metformin and medical nutrition therapy. And if it is less than that, it is normal and they need to be observed for future. So that is the immediate care pathway in the sense until you diagnose in 6 weeks, but long-term impact of gestational diabetes. Now, glycemia, the pregnancy is a condition where you need to increase the blood sugar. That is naturally happening with the changes in the beta cell function. And then before the pregnancy, it is normal insulin levels, but due to the placental growth or placental hormones, the insulin resistance develop and glycemia. But if the beta cells of Langerhans can control insulin, it will continue to maintain the normal glucose level. So, moreover, although it is considered a medical complication of pregnancy, it also carries a long-term implications. It's not only for the mother, but also for the child. So they have an elevated higher risk for lifetime. So as I mentioned, if there is chronic beta cell dysfunction and insulin resistance, the other features like glycemia, adiposity, impaired cholesterol levels, and increased blood pressure, they have a high risk of developing cardiovascular disease. And with the cardiovascular disease, they can have major adverse cardiovascular events or heart failure. And when they develop type 2 diabetes, there's a risk of retinal disease, kidney disease, and liver disease. So it is a life course perspective of Jdm. And there is already an underlying metabolic defect with an adverse cardiometabolic risk factor, and it can worsen over time with the aging and elevated lifetime risk for these outcomes associated with advanced complications of this disease condition. So they should be followed up long time, not only up to the pregnancy, they need prolonged consideration of screening and follow-up. Now, despite these recommendations of follow-up, most of the data reveals less than 50% of the women are taking Jdm partake in their postpartum glucose testing. There may be several reasons: social, financial, structural barriers, and receiving postpartum care. And these barriers may be preventing them getting this, and they may be needing to spend money, lack of health insurance, appointment waiting time, childcare, availability of transport costs, work demands, and all these lack of leave after the delivery. Sometimes they are the barriers of screening our women in our region. So when you compare to the other regions, we have suboptimal especially in our region. And transition of care from institution to the community may not happen ideally in our setup. And most of the time, if they are not referred to these institutions in the sense, the clinics, there's inadequate discharge plan from the institution of the communication, and there's a communication gap. And there's lack of uniformity of testing in the postpartum period. As I mentioned, different measures are taken, GTTs, fasting blood glucose, and hemoglobin A1C. And timing also, there is different variation. And the cost, lack of awareness, education on grassroots level care workers about this disease condition and follow-up. And there is very poor follow-up with their lifestyle modifications due to their attitudes, due to occupation and cultural habits in our region. So we have to look into all these aspects in our regions to get a better care, as it is not only a disease of pregnancy, as it is a disease of lifetime if it is not. So these are the different recommendations for American Diabetes Association. It's nice, every organization have different, but mostly it is the GTT which is mentioned for the postpartum care. So I have seen mostly women with PCOS, they are mostly found to be associated with good compliance, because they have, in addition to the glycemia, they have other problems with their menstruation, fertility, and obesity. All these have shown that they are attending better than the other women who are gestational diabetes when they finish their pregnancy. And recommendations, lowering prevalence of overweight, obesity, that is also important other than the blood sugar component. Health diets, including plenty of fruits, vegetables, dried cereal, leans, seafood, they are also important and better reduce all saturated fatty acids, fast foods, sweetened beverages. So physical activity carries a higher chance of controlling the blood sugar levels. So postpartum physical activity and exercise for 30 to 60 minutes, at least 5 days are advised to minimize these problems. And aerobic physical activity can substantially ameliorate insulin sensitivity and glucose profile, have a positive impact on cardiovascular health and improve mood and well-being and also the quality of life. And breastfeeding, longer the exclusive breastfeeding, they are protected against type 2 diabetes and obesity in women with previous Jdm. Contraceptives can be more important. It has a big role in overcoming poor adherence and interconception care. So intrauterine IUD, mainly PPIUD or Electrolyte, more suitable than the hormonal. If a hormonal contraceptive is an option, then it can be started 6 to 8 weeks after delivery if she's breastfeeding. Progestin-only contraceptives should be avoided given that they have been associated with increase of type 2 diabetes. So this is, I mentioned, it is not only the gestational diabetes, it is also type 2 cardiovascular disease, metabolic syndrome, impaired glucose tolerance, and type 2 diabetes mellitus, all in a circle. So we have to break this circle to have better life, and this can lead to the epigenetic changes and long-term alteration of fat deposition. So the risk of 4.69 with the first 5 years after delivery and 9.34 of more than 5 years have a high risk for Jdm people develop type 2, and up to a third of diabetic women would have obesity and other complications. So if you see the cardiovascular complications, women with Jdm have a higher risk of cardiovascular complications compared to the type 2 diabetes, and hazard ratio is 3.7 and 1.3% if they have not progressed to type 2 diabetes. If it is progressed to diabetes, 3.7. So cardiovascular disease is the leading cause of maternal and deaths among the world. That is one of the most common cause of disability adjusted life years in general. And this is unrecognized, and women are disadvantaged in terms of cardiovascular diseases if we don't control this. Recently, there's an open JAMA article, and it has been published last May 2020, effect of lifestyle intervention to prevent deterioration of glycemic among South Asian women in recent gestational diabetes. This had been conducted in our region, India, Pakistan, Sri Lanka, Bangladesh, and the conclusions have shown there is no, the study found the large population of South Asian urban settings developed dysglycemia soon after Jdm, and pregnancy and lifestyle intervention modified or in the COVID did not prevent subsequent glycemic deterioration. These findings are alternate or additional approaches are needed, especially among high-risk groups. So I think the study was conducted during the COVID epidemic, so it has not shown a big change in the glycemic level even with our lifestyle modification and diet interventions. So in summary, Jdm is a major public health and clinical concern. Up to 70% of women with Jdm will develop type 2 diabetes within their lifetime, causing medical, emotional, and financial burdens to the population. So as pregnancy is considered the window for future health, it's a testing time of the women. Taking advantage of this, women with gestational diabetes, appropriate screening, counseling, and support should be given to identify the future plans. So we have to have systematic partnerships between obstetricians, peripheral care users, community care users, to secure that transition is made properly and they achieve the detection and prevention and long-term prevention of this other, not only the diabetes, cardiovascular dysfunctions also is seen. So thank you very much. So that's all I have to tell. So it is not only a disease during pregnancy, it can carry, it's a metabolic condition, and lifelong follow-up is needed for these women to see the other bad outcomes. Thank you very much.
Thank you so much, sir. Thank you for such an apt talk on the immediate and late postpartum care and the future implications of that. So over to Chairperson, Dr. Pant and Dr. Radhika. Over to you.
Thank you, ma'am. Thank you, Dr. Ratnasri, for elaborating on the postpartum management of gestational diabetes, including the monitoring of blood sugar in postpartum period, contraception, and really they need long-term follow-up as they are at the risk of other systemic diseases, including cardiovascular disease, and so they need long-term follow-up, and really they are they need lifestyle modification. Thank you very much for highlighting on postpartum management of gestational diabetes patients. Thank you very much.
Thank you very much. Thank you.
So good evening to all. Thank you, Dr. Ratnasri. That was a very elaborate talk. I think continuum of care would be the point to be taken, starting from the physiological changes that happen in the postpartum period. And then you went on to highlight how important it is for these women to have a follow-up. So it is generally between 6 to 13 weeks. Looks like majority of the bodies, the academic bodies agree at the time between 6 to 13 weeks, because that is the time where the changes of insulin resistance would have reverted after delivery. And it's an important point also to be noted that these women need to be talked about the control of weight, continue breastfeeding. Breastfeeding itself is quite protective, and the use of exercise. So the behavior modification, I think we talk about opportunistic counseling for contraception. I think this is also a window of opportunity to prevent the epidemic of diabetes that is now happening in the South Asian countries. So women, I think, are very difficult to catch, and this is the right time for these women to be, spoken to. And a very important point that I noted was you highlighted that the fasting blood sugar after 6 weeks, if it is less than 120 milligram per percent, they are the women who are at a lower risk of developing diabetes. I think that's an important point to be noted. And the fact is, another point of concern is less than 50% of the women present for a follow-up because of various reasons. Probably the information was not communicated to them appropriately, and the logistic concern, the financial concerns that these women have. So I think it's been an eye-opener for all of us, quite informative. So I congratulate you for this talk, and thank you so much for this academic session. And also, I wish to thank Dr. Sadhna for having me here, and Dr. Amrita. You're really doing a great job. So thank you so much.
Thank you, Dr. Radhika. And I wish to share that we have done a similar series of 5 webinars along with Dr. Radhika and Dr. Richa Sharma, and to Dr. Padam Rajpan, Dr. Rohana, all the leaders of CEPOG is there. So Dr. Radhika has been one of the a very, very important person who is trained and who has been invited for the how to make guidelines and how to do the evidence and experiencing. So Dr. Radhika, we will really like to have all of the CEPOG committee, Dr. Padamraj, Ratnasri, all so many leaders are there. So we will like to have your association and your expertise for many things in CEPOG, and we will like to have your suggestions also that how we can culminate as a whole CEPOG region our evidences, and that turn to a very strong statement in the women's health. So thank you very much to being here, and over to Amrita for always being there, and she has to work hard with me, and she is always there for me. So thank you, Amrita, and then you can conclude the session. And if there is any question, we don't
I have a small comment to make, Madam. The fact that you highlighted that we need to get together in the CEPOG region, have guidelines which are contextual, and also practice. It could even be practice recommendations which can be translated into practice. So we need to have that for our region, because we all know WHO is working hard in that direction, but it can't be one body which is doing that. So I'm really glad that you brought up this point, and it would be certainly my pleasure. I would be very happy to work with everybody here. So thank you so much.
So Dr. Padamraj, we can take advantage of Dr. Radhika, and that the like-minded people trained in the other all CEPOG country, and we can do really something collectively.
Nice, thank you.
Thank you, ma'am. And I can see all praises in chat box. All the talks were well appreciated. I could just find one question that was for Dr. Aparna Sharma probably. And that was, should we do quadruple marker if the dual marker is negative in the diabetic patients? So anybody can take up, I think.
I can take it. If the first trimester screening is negative and the targeted images, like for diabetes, we usually do the anomaly scan or a very good anomaly scan in the second trimester, if not at all, if not the full TPA. So if the first trimester screening is okay, perfectly normal, and the targeted images is also normal, then we don't have to repeat quadruple marker in majority of the patients. But if the first trimester screening has been missed somehow, then it is for GDM patient, we should because they are having a little bit inherent risk, especially the pre-detected, like the pre-pregnancy diabetes, then we must do the quadruple screen. So Aparna is not there. Dr. Radhika, your comment. If the first trimester screening is negative and the anomaly scan is also okay, then is there need to do quadruple test again? Radhika, your comment. Yes.
Yeah, I can hear that. So I do agree with you. If the first trimester, the dual marker was normal and the anomaly scan is okay, so I do agree with you. The quadruple test may not be done. But then there is a huge difference of opinion. The world is full of literature. It's full of controversy. I don't think we have the final word yet. Like we all agree that it has to be contextualized. We are a resource poor country. So, and then we have variation in practices. There are patients who are well informed. They come and discuss with you and they insist, because everything has its own positives and negatives. What is important is you undertake a test. Counseling of the patient is extremely important. Screening tests are only to be done if the patient is ready to go ahead with the confirmation test. So these tests are basically for screening. Confirmation is a must. It adds to the stress. So of course, we need to take the patient into the loop and see the risk versus benefit. And I do agree with you, this can be certainly avoided.
So last comment from Dr. Padamraj, our chairperson, and then Amrita, you can conclude with a short vote.
Thank you. Thank you, President CEPOG, Secretary General CEPOG, all the speakers, Dr. Amrita. My special thanks to Dr. Sadhna, ma'am. Thank you for your effort. And this is possible because of your effort. Thank you very much. And thank you all the audience, and we'll come among you next time once we'll decide with the Sadhna ma'am for next topic, and next month we'll come again among you people. Thank you very much. Thank you.
Thank you, sir. You did my job. So at the outset, I would like to thank Sadhna ma'am for giving me the opportunity and meet you all on this platform. And I thank our President, SAFOG, and our Chief Guest, Dr. Ruhana Hatatua, our special guest, Dr. Alka Kriplani, and guest of honor, Dr. Yusuf Latif Khan. I would like to thank Chairman, NCT Committee, Dr. Padmaraj Pant, and all the chairpersons who joined us today and spared their time with us, Dr. Sadia Ihsan, Dr. Farhana, Dr. Laila Arjuman, Dr. Purturji, Dr. Sadhna Gupta ma'am, Dr. Ganesh Tangal, Dr. Radhika. So thank you, respected chairpersons. Your inputs were great and we are all benefited. And the speakers were superb and they did they enlightened everybody, including the chairpersons and the guests. Speaker Dr. Aparna Sharma, Dr. Gorak Mandrupkar, Dr. Laila, and Dr. UDP Ratna Siri. So thank you all, Dr. Lubna, I'm sorry. So thank you all, and thank you all the attendees, because of you, we are all the efforts, they seem good, otherwise everything goes in vain. And thank you, Team Shield, for giving us a wonderful platform and good connectivity so that we could stay here for so long. So thank you all, and a very good night. Time to part.
I shared you this recording of the program, and the audience can like note down, and we will share in our group also. Recording.
Yes, I have shared in chat box.
Yes. Okay.
Thank you.
Chitra, you can like close the meeting, and good night, good evening, everybody.
Good night. Bye.